marked with the bottom area.
Okay.
Are there a lot of people out in the hallway or anything? Yammering.
I forgot the name of that actor.
So we've been reminded that today is for some a holiday. The state does not observe Columbus Day as a holiday any longer. So we felt safe in choosing the state because the private sector doesn't take it as a holiday, the state doesn't. But unfortunately, we have a smaller crowd than we would like for such an internationally famous speaker and such a life and death issue. And I have to say, from the standpoint of my family, the work of the cardiologists here that we're working with, Dr. Balmer, Dr. Skye, Dr. Budoff, in particular, has been truly life-changing for me, for many of my family members, friends, and Victoria Dupuy, if you would just wave your hand. This woman is such a doer and has made such a difference in so many lives by taking the knowledge and getting it out into the community through mobile scanning, first in Silicon Valley where she lives, and she's broadening it to other communities. We'll hear more about that later. But I have been so moved by what I've learned over time on this issue, and I meant to bring up to the podium with me this guide that has been printed by the California Department of Public Health. These are our RightCare materials. You should all have them at your tables. And if you don't, there are more that we can distribute. But we've worked with the head of preventive cardiology for Stanford, Dr. David Marin, and many of the cardiologists in the room today to synthesize a lot of the material, starting on page 5 of your booklet, if you wouldn't mind opening this to page 5. So once you get to page 5, honestly, some of these graphs have been so difficult to really understand. I'm not a physician. I am trained in changing public policy, and I've done a fair amount of that, regulating the healthcare industry and getting legislation through. And this graph on the bottom left corner of page 5 took me a long time to understand because it's multi-dimensional, but it's one that I really want to help others to come to grips with, and that is that when a person gets a calcium score, which we're going to be learning a lot more about today, if they keep their other risk factors absolutely pristine to the ability that they can, it still does not prevent quite significantly higher event rates and death rates for those who have the higher scores. Carolyn, please come up to the front if you would, because I want to be sure to get a photograph with Dr. Carolyn Peck from the California Department of Public Health. Will you be with us for the whole day? I will. Oh, wonderful. Okay, so we'll do a photograph with Dr. Budoff though now, and Brian, you have a camera ready, correct?
Yes.
So you never know with a top state official whether they might be drawn off quickly. But Dr. Carolyn Peck, this is the famous Dr. Matthew Budoff. So this award is the RightCare Initiative Visionary Leadership Award 2019 for precision prevention of heart attacks and strokes. And this man I owe my life to, and so many others that I know. And so let's get out in front of the podium and get some better photos. And I don't work for the state anymore, so I can say, God bless you, Matt Budoff.
3, 2.
Thank you very much.
So I won't walk you through the rest of the booklet, but I do want to thank the California Department of Public Health for having produced 300 copies of our materials, including our coronary artery calcium brief, which cardiologist Bill Baumer led the writing of with David Marin, the head of preventive cardiology for Stanford, Dr. Joe Skye, the Air Force guy, Dr. Matt Budoff, who is our primary speaker today, and some other famous cardiologists who are expert in this topic. So with that, I just want to say thank you for being here to listen, learn, and help strategize about how to make this more available to help other families like mine to not know that they have high risk and not get the very effective treatments that are available now. So thank you for being here. Dr. Skye, did you want to talk a little bit about the military to introduce Dr. Budoff?
Thanks everybody for coming. And as some of you may know, prior to becoming a cardiologist, when I was an internist, I worked at the School of Aerospace Medicine, where I led the internal medicine branch, which there were 2 cardiologists that were assigned, and a over 50-year history of tracking and keeping safe the pilots and early astronauts from the earliest days of flight. And starting in the 1950s, of course, observations were made that coronary calcium was present in the major arteries, including the coronary arteries. And formally, starting in 1982, the School of Aerospace Medicine started using coronary calcium as a predictor for events. And as I presented before, as Dr. Budoff will present, it's one of the strongest predictors, and it's one of the tools that made both military flying and selection of astronaut candidates one of the most more reliable ways to know how to prevent disease. And interestingly enough, the connection was extended into other branches of the military as Walter Reed started offering the same testing that was being offered to pilots and astronauts to retirees. And that data was published last year for the Walter Reed cohort. And again, it showed an amazing tool that can be used to predict and help guide treatment. And then the Army also did a study in younger recruits and showed, as other data has shown in the Kaiser system as well, that a coronary calcium score in a young person is a significant predictor of events. And so I, for one, recognize the value of observational data, even retrospective, and don't need it to be randomized because it's something that we can see, and we can see the cohort and watch. So I'm looking forward to Dr. Budoff's presentation on coronary calcium.
So this is your second welcome for those of you here on Columbus Day. And remember that Columbus started out, he had no map of where he was going. He just took off to see where he could wind up. And that's a little bit of the history of Dr. Budoff, who in fact started out looking for ways to, in fact, develop a map for cardiovascular disease to detect where it is and where it would go. And of course, in the early days, no one knew what would happen. EBCT came out, and it was an early way of scanning for that. And we had other things like carotid Doppler and other things to look at atherosclerosis. It turned out that he focused on an area that was coronary calcium that turns out to be the preeminent risk predictor for cardiovascular disease. It is the best risk predictor of all the things we have, ankle arm index, family history, all of those things. So he was able to focus on that, and partly because he was able to focus very carefully on that and then do and participate in the clinical trials, we have the information that we have here today. The coronary calcium CT that he is going to discuss today is one of the preeminent risk predictors, and as we were discussing earlier, actually trumps other risk predictors in accomplishing that. So Dr. Budoff has a very accomplished career, as you can imagine. He is currently professor of medicine in the Endowed Chair of Preventive Cardiology at UCLA. He is also the program director there, the training program director, which is important because that's where young minds go to learn and be educated, and he's responsible for that. It would be all day for me to list his multiple awards, publications, and recognitions that he has for that. You saw one of the awards presented here earlier today. He is currently program director, as I said, of Cardiology Fellowship and director of the Cardiac Computed Tomography Program, and he works at LA Biomed as a director there as well. So he has a career that is distinguished, a career that has focused on helping patients and reducing cardiovascular disease. And we're delighted that on Columbus Day, he was able to find his way to Sacramento and to tell us about his exploratory directions and what it means for us today as clinicians and what we should offer for our patients in reducing cardiovascular disease. Dr. Budoff.
So it's certainly an honor. We're actually, our hospital's closed, but not for Columbus Day, for Indigenous Peoples Day. So it was easier to get away today because I wasn't missing work. But it is an interesting time. We've had an incredible uptake on the utility and guidelines related to looking at the coronary calcium scan, which represents decades of work, people before myself. Bruce Brundage, people like Jim Adams, who's in the audience, and others who've been using this test for a long time, despite some resistance both at the payor, patient, and physician level. I do have a grant support from General Electric, and they do manufacture one of the many machines that can measure coronary calcium. So the problem that we've had in preventive cardiology, so as a preventive cardiologist, my goal is solely to try to prevent premature death, right? And the number one cause of death among men and women today is heart disease. And it's unfortunately remained the number one cause of death. We thought by now perhaps cancer would have surpassed heart disease, but actually heart disease is actually taking a turn up with more deaths. So it's still ahead of cancer as the number one cause of death. So we have these risk calculators, and these have been widely published, and they're supposed to be widely used. And you calculate different things. You put in whether they have diabetes and whether they smoke and what their blood pressure is and how old they are and their ethnicity and race, and you come up with a number. The number tells you what their risk of having an event is, and the problem with the risk calculators generally is that they grossly overestimate risk. And the problem is when you overestimate risk is you put a lot of people on therapy that don't need it. And when patients start to perceive that maybe they won't benefit, they stop taking the medicine. So there's not only the obvious problem, a lot of cost. Even though these drugs are largely generic, they require follow-up, they require labs, they require follow-up labs. They come with some side effects, measurable side effects like rhabdomyolysis, which is muscle breakdown, which can harm patients. And we're grossly over-treating patients with these guidelines. So this is from Northern California data. This is 307,000 patients. In red is what, or in orange, is supposed to be what should have happened as far as the event rates. So in the higher risk group, 8% of patients should have had an event. In this group, 4% of patients should have had an event. And in blue is what happened. About 4 times less, even more than 4 times less. So an overestimated risk by 400%, which is pretty much the worst validation or correlation you can get probably in preventive medicine. It's hard to do this, to be so off by 400%. We're not talking about 10% variability or 20% variability. We're talking about a factor of 4 for every category. Very low risk, 5 times wrong. A low risk, about 6 times wrong, 5 times wrong. Oh, sorry. Very sensitive mouse. Low to intermediate risk, over 4 times incorrect, and almost 5 times incorrect for high risk. So it just doesn't do a good job in identifying who needs to be treated. So that's a big problem by itself. The second problem is that just calculating somebody's risk and telling them you have a 5 or 7 or 10% risk over the next decade having an event is not that compelling for patients either. They don't say, oh my gosh, I have a 4% risk of having an event, I better start all these preventive therapies. So there's no urgency to treat from the patient's perspective, and therefore compliance and adherence tend to fall off. So the new 2018 guidelines, for the first time, really elevated coronary calcium scanning to help with both of those problems. What we call calibration, getting the right people treated, and compliance, getting the right people to stay on therapy, right? Because we can choose the right care, right? As we're here today, we can pick the right therapies, but if the patients don't continue to take it, that doesn't help them. I don't think being prescribed a cholesterol pill will help somebody unless they actually take the pill. I don't know, maybe it's a study that Dr. Bomber and I could do to see if just getting the prescription lowers their risk in some way. So the new cholesterol guidelines now advocate for more therapy when they have established heart disease or atherosclerosis in the heart, and less therapy when they have none. And that makes for a wonderfully good precision medicine. It allows the risk of an event to be correlated with the intensity of therapy. We can give more therapy to those people who are found to have more plaque and less therapy to those people who are found to have clean coronaries. It's not a lifetime guarantee, just like an HIV test. It's not a lifetime warranty that you'll never get the disease, but it's a good predictor for the next 5 years at least. If you have a score of 0, you're not going to have an event for the next 5 years at least, and you can get retested or you can consider those therapies. Obviously, everything we talk about today is in the context of a patient-physician discussion, but this is a very direct way at identifying who should have that discussion and who should have maybe a more stern discussion when we find people with more severe disease. So, a complicated risk algorithm, but at the bottom of all of this, if the risk decision is uncertain, consider measuring coronary calcium. If you get a score of 0, lowers the risk. Consider no statin for 5 to 10 years. Calcium score 1 to 99 favors statin, and calcium score above 100 or above the 75th percent when we compare people to similar age and gender, so you have a lot of plaque for you, that would initiate statin therapy. So that's the general guidelines, and let's go about where it came from, again, the same thing. So this was widely published and widely, a lot of press releases. This is from AHA. This is what they said from the American Heart Association at the time that the test was advocated. This is the day that those guidelines came out. Coronary calcium test can help clarify heart disease risk and control cholesterol. So they saw it as a big step forward. But what does calcium really tell us? A score of 0 is not absolutely no atherosclerosis whatsoever, but it's probably either none or very, very little, to the point where your risk of an event is very low. So simply, calcification is kind of like the tip of the proverbial iceberg, right? If the Titanic's going downstream and it sees a big iceberg off its bow, it doesn't say, okay, let's send some divers below the water to see if there's any ice below the water that can rip the hull of the ship. It knows what to expect. And the same is true of coronary calcium, right? This is our calcium. The calcified plaque represents about 20% of the overall atherosclerotic burden. So the bigger the calcified plaque, the bigger the problem is. The more fibrotic plaque they have and the more lipid-rich plaque they have. So it might actually be the lipid-rich plaque that's the most vulnerable or the most worrisome, but we use this calcified plaque as a simple marker. The reason is that calcium is readily visible on a CT scan. So when we do a CAT scan of the heart, it doesn't require any needles, doesn't require any injections. You can lay down basically as you're dressed right now and get a scan. The whole test takes about 30 seconds to acquire the data and to get you scanned. So it's quick, it's easy, it's very low radiation. It's about the same as a mammogram. And my boss, Bruce Brundage, who introduced me to this test back in 1991, when I got started with research on this, called it the mammogram of the heart. He said very simply, you will get a scan, you will identify who has the problem, and we can start treatment, just like a mammogram may identify a lump or a mass, or you'll find out who doesn't have the disease, like a normal mammogram, and you don't have to worry about that person for some period of time. It applies obviously to both men and women, more specific than mammography. So does it really work? Well, these are the statistics, but I think that even just thinking about this in general, you'd understand that the net reclassification is basically what percent of patients who get the test get told that they're in a different category. How many people does it really fix? And we do a lot of tests today that don't really help that much. For example, this C-reactive protein is a blood test, a marker of inflammation. It's widely covered by insurance. It's widely done in practice, and it's really a rather poor test of identifying who's at risk. Because there's so many things that can cause inflammation, and not everybody who has heart disease has active inflammation, that it just misses most people. So it reclassifies about 7% of patients. So that's not great. We have family history, that's better, that's 16% of patients, but still, just getting into a detailed family history about patients' first-degree relatives only reclassifies about 1 in 6 people. Whereas getting the calcium score reclassifies about 2/3 of people. For every 3 people who get a scan, 2 of them are told, no, you're not intermediate risk, you're not kind of on the low or intermediate risk, you're either high risk or you're very low risk. And that's really helpful, because high risk, we have a lot of great therapies that we can apply to that. Blood pressure control, aspirin, cholesterol medicine, etc. And very low risk, we can say, you know what, heart disease is not your problem at this point in time. Let's focus on other health issues, and we can retest you in 5 years. So the different societies, this is the European Society of Cardiology and the AHA-ACC Primary Prevention Guidelines, both have come together to basically say the same thing. And it's important because you really want the world, it's not a US-only problem, to envision this in kind of a similar way. And both the European Society of Cardiology has come out with a 2A recommendation, which is fairly strong. It's not a mandate that everybody has to get the test, but it's a strong recommendation to use the test, just like the American guidelines. 2A recommendation, strong recommendation to get the test, but not a mandate that you have no choice but to get the test. And they say that quantification of coronary calcium improves stratification in subjects at very high versus low risk for coronary events. Right? That's what we want. I want to know who's low risk let's stay with lifestyle and diet, let's think about other things right now, or who's high risk. You're worried more about getting your traditional mammogram, that's important, but let's also worry about your heart disease because you have underlying heart disease and that might claim more lives in that setting. So it helps match intensity of risk with intensity of therapy. It also allows people, and it's important that they state this, avoiding therapy in subjects with low risks that have low 10-year event rates. So we can avoid therapy, and that's really a very important algorithm of care. So if we look at this bar, this is intermediate risk, right? That's traditionally what we've called intermediate risk. So that means we don't know, right? You're in the middle, right? You're not intermediate pregnant, you're pregnant or you're not. You're really not intermediate risk. You're either high risk or you're low risk. But the risk calculators don't really help us always get it out of this gray zone, as we call it. So this gray zone, or this orange zone in this picture, is the intermediate zone. So what happens if you apply a calcium score to this population? This has been done, this is a population-based study done in Germany, but there's been about 10 of these studies, and they're all almost identical, all over the world. Rotterdam, United States, there's one done in New York, there's one done in Los Angeles, there's one done throughout the US, they're all the same. About 1 out of 7 patients are not intermediate risk, they're high risk. They have a lot of coronary calcium and they need treatment now. So we misclassified them. The more important probably is this group. And this is what we now call the power of 0. That they have no coronary calcium, they have 0 score, and they're really not intermediate risk at all, they're very low risk. And we know the event rates in this group approaches 0%. So a 0 score, meaning no detectable coronary calcium, equates with basically a 0% risk over the next 5 to 10 years. And there's a lot of data there, a lot. So we now call this the power of 0, and we can down classify some patients. And that's where I think we're really going to get a lot of traction because of that risk calculator that a lot of doctors use, overestimates risk by 4-fold. We can now say 3 out of 4 of those patients, right, are not at increased risk like the risk calculator said, they're really low risk. And this is a better risk predictor than the risk calculator. We know that again from many, many studies.
Before you leave that slide, it's a little hard to understand that slide. So, oh, I couldn't even see it over there. Okay, so here it says 63% are reclassified to low risk.
Yeah, 2/3, yeah.
Oh, okay. Can maybe put that instead of in yellow writing to black writing or something? It's not visible except if you're really close. So that's a huge number. 63% have 0, or?
Of that intermediate risk group, yeah, more than half. Of all people ever scanned, half have scores of 0. 0 is a very, very common number because half of us will not die of heart disease. We know that. And this test will tell us which half you're in the half that's more likely to have heart disease, or the half that's not going to get it. We don't all get heart disease, that's right, we know that. Heart disease claims at most about 1/3, maybe 40% of Americans. So this gives us a 50-50 split.
Could you clarify for me, because I'm ignorant of this. When you say the coronary calcium look, are you looking specifically at the coronary arteries or just calcium in the heart?
Yeah, let me show you. I think I have a picture coming up here.
Thank you.
Yeah, I'm sorry, it was earlier in the slide deck. Actually, maybe Bob took it out. I guess we lost our picture. Sorry, yeah, it was in the picture. I think we got rid of it. Yeah, I apologize. Somebody else
But you
kind of
do have
tweaked
it
the
in the
slides.
book. Okay, so in the book, on page 7 of 31, you see the calcium.
Oh, okay, a little picture there. So it's literally the arteries themselves, that little thumbnail at the bottom.
Gotcha.
It's, yeah, I apologize, it was in here somewhere, but
So it's not the
Yeah.
valve, that's
it's not the valves, it's only the coronary arteries.
There's that
Yeah.
one, and then there's that
Yeah,
one.
that was, yeah.
I'll just leave that
That's
there
all
in
right.
case it's helpful for anything.
Page 8, at the bottom of page 8. You can see literally, this is the picture that I had in my talk, but it literally looks at the calcium in the arteries themselves. We're not talking about the valves, we're not talking about other places in the body, and it has nothing to do with calcium intake. So don't confuse calcium pills or calcium supplements with calcification of the arteries. This is a pathological process. Plaque breaks off, kind of gets walled off, and calcium builds up. So it's a very simple thing, and it's completely computerized. So I don't eyeball it and say you have a score of 82 or you have a score of 130. We measure it, and